This podcast episode is produced in collaboration with the Cardiometabolic Health Congress with IME funding from American Region. Please follow the link in the show notes for CME. Of course, all CardioNerds education is planned, produced, and reviewed solely by CardioNerds. And with that, let's get on with the show.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, CardioNerds. This is Amit Goyal. In this episode, we will dive into the intricacies of iron deficiency in heart failure. Kicking us off is a chair for the CardioNerds Heart Failure Committee, Dr. Jenna Skowronski. Jenna is a Pittsburgh native. She completed her internal medicine residency, medicine chief year, general cardiology fellowship, and fellowship chief year, all at the University of Pittsburgh Medical Center. She's since moved to Nashville, Tennessee for advanced heart failure and transplant cardiology fellowship at Vanderbilt University, while still working on her master's in medical education at University of Pittsburgh. She plans to have a career that blends heart failure and cardio-obstetrics, in addition to a focus in medical education. Jenna, it's been so amazing working with you as a cardio nerd these past few years, and it's great to have you back on the show.
Amit, thank you so much. I'm so glad to be back on the podcast, and I'm exceptionally excited to introduce Dr. Shazli Khan. She is an Ohio native where she attended medical school at the University of Toledo before joining me in Pittsburgh at UPMC for her internal medicine residency, where she was my absolutely stellar intern and resident. She then moved to New York for her general cardiology fellowship, where she is currently a third-year fellow at New York Medical College, Westchester Medical Center. She plans to pursue a career in advanced heart failure in the future. She had a particular interest in infiltrative cardiomyopathies as well as palliative care in heart failure. Shazli joined CardioNerds as an Academy Fellow. Welcome, Shazli. I'm so excited to get to do this podcast with you.
Thank you so much, Jenna. It feels so great to be working together again and talking about such an important topic in the field that we both love. I have the great honor of introducing Dr. Robert Mentz. Dr. Mentz went to medical school at Emory prior to completing his residency training at Brigham and Women's Hospital in Boston. He then moved to North Carolina to complete his cardiology fellowship at Duke and hasn't left since, completing training in advanced heart failure and clinical research prior to transitioning to faculty. He's now the chief of heart failure at Duke University, as well as the editor-in-chief of Journal of Cardiac Failure. Dr. Mentz has also been an extraordinary mentor to the broader CardioNerds platform and was absolutely instrumental to the creation of the CardioNerds Clinical Trials Network.
Shazli, thanks so much for that kind introduction. It's really great to be with you, and I'm looking forward to our conversation tonight, and good to be back with Jenna and Hamid as well.
Dr. Mentz, it's such an honor to have you with us today on today's episode, discussing what has certainly been a topic for debate over the last 2 years in the heart failure world. And as the title of today's episode is aptly named, we hope to really iron out the data over the last decade regarding iron deficiency in patients with chronic heart failure. So let's dive right in and start with the case. Miss Ferritin is an 80-year-old woman with a history of heart failure with reduced ejection fraction and hyperlipidemia. She was initially diagnosed 5 years ago when she presented to the hospital with leg swelling and shortness of breath. At that time, an echocardiogram showed a left ventricular ejection fraction of 25% and an end diastolic dimension of 6.4 centimeters with moderate functional mitral regurgitation. Coronary catheterization showed non-obstructive coronary disease. During that admission, her labs were notable for a sodium of 137, potassium of 4, and creatinine of 0.9, and her CBC showed a hemoglobin level of 10.9 with a normal white blood cell count and platelet count. Her astute medical team at the time worked to up her anemia, which was notable for an iron level of 24, ferritin of 17, and an iron saturation of 11%, and discharged her with oral iron ferrous sulfate 325 milligrams daily, which was continued by her PCP. So before we go further, Dr. Mentz, what do the results of her workup mean to you, and how commonly do you see this in patients with heart failure?
Yeah, thanks so much for putting together this nice case. And I think this illustrates a couple key points that you're already getting at. So first, we have a patient relatively recently diagnosed with heart failure with some concerning signs as you just think about poor prognostic measures, low EF, dilated ventricle with mitral regurgitation as well. The team did a nice workup trying to understand underlying etiology of cardiomyopathies and ruling out ischemic disease, and then looking at a number of different laboratories. And as you've just summarized here, noting the anemia as well. So renal function normal, but does have underlying anemia. And importantly, I think many of us were taught in our medical training, when you see anemia, to think about iron deficiency. But one of the key messages for that we'll definitely be discussing today is the argument of, when you see heart failure, I really think we need to be thinking about iron deficiency. And we'll talk a lot about the different criteria, but the team did a nice job here about seeing anemia, thinking about iron deficiency, and then sending off some of these lab tests that are really critical to understand that, both the iron levels, transferrin saturation, and the ferritin levels. So my key kind of bullet points in this section would be, we've got to think about iron deficiency, and we'll talk more whether it's with or without underlying anemia, and importantly, just how common iron deficiency is in patients with heart failure. And then the final real key pearl is that the standard criteria that have been used and have historically been reported in the guidelines are, for iron deficiency and heart failure, it's a ferritin less than 100 or 100 to 300 with a TSAT that's less than 20. So we'll come back to that a couple different times, but really highlighting how common this is and how do we diagnose iron deficiency.
Yeah, Dr. Mentz, that was great. And I want to highlight a key point that you were bringing up here. So, specific to the scenario, she was tested for iron deficiency because of her anemia. Let's say she didn't have anemia. Which patients with heart failure are you testing for iron deficiency, and how do you go about that evaluation?
Yeah, this is a really important piece. And I think as we'll talk into the trial data and the epidemiology, I think there's a recognition now that in all patients with heart failure, how common it is to see iron deficiency, and that it really shouldn't be the anemia signaling this, but rather in the outpatient setting, or particularly in the in-hospital setting, we know that the prevalence is even higher. So the guidelines, as we think about that, they do actually describe that when you have a patient with heart failure, it's a class 1 indication to think about underlying etiologies and to check iron indices. So broadly in heart failure, we should check for iron deficiency, and then those criteria. And this is an area that's evolving a little bit, because most of the trials have used the ferritin less than 100 or 100 to 300 with a TSAT less than 20. But we're increasingly wondering if we could be ferritin agnostic and really just focus on the TSAT level. So we'll come back to that, I'm sure, here in a couple minutes, but really just the key message of thinking about iron deficiency and heart failure and sending this. It's easy to check, routine labs, and you can check in the inpatient or outpatient setting.
That's great, Dr. Mentz. So it really sounds like in all patients with heart failure, independent of anemia, we should be screening these patients. So Miss Ritten explained to her PCP that she knew she was having heart problems, but she wasn't sure how the iron supplement was related and if it was also important to take this iron for her heart specifically. So what do we know about the impact of iron deficiency on heart failure?
Yeah, so this is an important space, and there have now been a number of key studies that have helped us really tease out the relationship between iron deficiency and heart failure. And the kind of key points are that upwards of 50–60% of patients with heart failure have iron deficiency. Importantly, it's regardless of whether it's reduced ejection fraction or preserved ejection fraction. And that we know that iron deficiency is associated with worse outcomes for patients with heart failure in terms of worse quality of life, functional status, if you look at measures like 6-minute walk distance or peak VO2. Then importantly, it's strongly associated with increased hospitalizations and increased mortality even. So this really does have a huge impact on our patients. It leads to worse quality and quantity of life. So we need to be thinking about iron deficiency. And then you say, well, why are we seeing so much iron deficiency in heart failure? And there's been some nice studies that have teased this out, but it's basically each step of the pathway is impacted in patients with heart failure. So many patients living with heart failure tend to take in less iron in their diet, so nutritional variation. And then even if they are taking in iron, it tends to be less easily absorbed. So there's actually a reduction in the ability to even absorb iron. And then the next piece of this, it's kind of one step on top of the other, but even if it is absorbed, it tends to actually be sequestered and not able to be used effectively because of underlying inflammation that rises hepcidin levels is kind of a key pearl there. And it leads to iron being sequestered. And then the final piece is many of these patients are on blood thinners, antiplatelet agents. So you actually have increased loss of iron through bleeding, whether in the stool or otherwise. So unfortunately, it's a multitude of different reasons that lead to low stores, less effective utilization. And some more recent studies have demonstrated that it's not just impacting the heart, but also the skeletal muscles. So it's probably whole body is really impacted by iron deficiency in our patients living with heart failure.
So it sounds like her iron deficiency is greatly impacting her in terms of her heart failure. At the time of her initial diagnosis, she was diagnosed with idiopathic dilated cardiomyopathy. Her cardiologist started her on metoprolol succinate 100 milligrams daily, sacubitril valsartan 24-26 milligrams twice a day, spironolactone 25 milligrams daily, and empagliflozin 25 milligrams daily. She had also been on a maintenance diuretic with furosemide 40 milligrams daily. Unfortunately, her metoprolol and sacubitril valsartan could not be up titrated due to symptomatic hypotension. Although Miss Ritten was initially improving, 3 years later, she felt that her symptoms plateaued and she continued to report NYHA class 3 symptoms despite all of these medications. So when she was readmitted to the hospital, her iron studies were again consistent with an iron deficiency anemia, revealing a ferritin level of 102 and an iron saturation of less than 7%. She told her team that she was only intermittently adherent to her oral iron supplement as it caused her some constipation issues. She was admitted for IV diuresis and slowly improved symptomatically. So, at this point, is her oral iron supplement sufficient to treat her? And if not, what other treatments would you recommend while she's admitted to the hospital?
All right. So this is a great case that has a number of really important teaching points. I'd be remiss if I didn't talk some about other background therapies. So I think you nicely summarized she's on underlying quad therapy at the max tolerated doses. And I think a key pearl there is always thinking that there's some concern about some of the symptomatic hypotension. Better teasing that out and understanding, goodness, can we actually go up on her ARNI or her beta blocker? But it sounds like probably not. So she's on maximal tolerated therapies now, and she's still symptomatic. So, in addition to pharmacotherapies, we need to be thinking about other really effective guideline directed approaches, including cardiac rehab in this patient. So, in addition to that, now, so we've got her in the hospital, symptomatic, and we're worried about her iron deficiency. A really important pearl here is that oral iron has not been shown to be effective in patients with heart failure and iron deficiency. For those that want a deeper dive into that, you can look at the Iron Out trial. That was iron deficiency, HFrEF, in giving oral iron. It was not found to be beneficial in terms of measurements of peak VO2 or oxygen consumption. And importantly, it really looked like the reason for that was probably that the oral iron was not absorbed in most patients and really just not effective. So as you can see here, she was even struggling with it, some related to constipation. So as we talk about effective therapies that we're starting, I think we also can talk about deprescribing therapies. And this is a great example where I would stop oral iron in this patient and really underscore that iron deficiency needs to be treated with IV iron in patients with heart failure.
Thank you so much. That's really helpful. I know when I was a resident and a general fellow, I don't think I really fully understood the distinction between oral iron and IV iron, but it's helpful to remember because we see a difficulty absorbing medications in our heart failure patients with a lot of different things. So thanks for that. I know we've all seen a number of randomized clinical trials done in this space, particularly learning about the confirmed HF and FAIR-HF study, which I learned about years ago now at medical school. But more recently, the data presented in Affirm, AHS, and Ironman, and perhaps most recently in HeartFin trial that you and your colleagues have published. So how do you iron out all of this data in terms of who to treat, when to treat, formulation of therapy, and what outcomes we're hoping for with treatment?
Yeah, really good points. And for those maybe less familiar with some of the studies, so just got quick bullet points here. So the first key trial of IV iron in heart failure with iron deficiency was FAIR-HF. It showed improvements in quality of life and functional status, giving IV ferric carboxymaltose, one of the IV iron formulations. And then a follow-up study, CONFIRM-HF, confirmed those benefits of giving IV FCM or ferric carboxymaltose with pretty striking benefits around 6-minute walk distance. So actually a 30-meter benefit in terms of improvement in 6-minute walk, really clinically significant. So it was after those studies that guidelines in the clinical community began to use IV iron to improve the function and feel endpoints. So quality of life and functional status for our patients. And then in more recent years, you've now just highlighted three of the key big outcomes trials. I'll rattle these off quickly. Affirm AHF really relates to our patients. So that was EF less than 50% in the hospital with heart failure, with iron deficiency, gave ferric carboxymaltose and looked at clinical outcomes. Primary endpoint, cardiovascular death and total heart failure hospitalization in over 1,000 patients. It showed a nominal reduction, really driven by heart failure hospitalization. It was technically a neutral trial. It was dramatically impacted by the COVID pandemic. And in a pre-specified analysis accounting for that, it did meet nominal significance. So you say, Rob, you're kind of talking through a lot of different numbers here, but the kind of key summary from Affirm was a large study showing that IV iron was safe and it led to likely a reduction in heart failure hospitalizations. But that's the first trial. And then subsequent to that was the Ironman trial, a different IV iron formulation, FDI or ferric isomalt. Again, pretty similar in terms of some of the design features to Affirm, but different formulation. It was reduced ejection fraction, but actually an open label study. So it was not a blinded study like Affirm was, but had the same endpoint and actually interestingly showed a similar numerical reduction in that endpoint of heart failure hospitalizations and cardiovascular death, about 20%. So theirs was 18%. Also, technically a neutral study, the p-value was 0.07 and also impacted by COVID. And in that case, similar pre-specified analyses. In that case, when you adjust for COVID, suggested about a 25% reduction in that endpoint. So that led to a growing suspicion and belief that IV iron in now multiple different formulations would reduce heart failure hospitalizations. And it was actually right before we presented the HeartFit trial that the most recent European cardiology guidelines were updated. And we'll come to the guidelines in a moment. But right after their guideline recommendation, now with a class 1 recommendation for quality of life and functional status, they gave a class 2 recommendation for heart failure hospitalization reduction. Then the very next day, we presented HeartFit, which we can talk to in more detail, but a large trial over 3,000 patients, HFrEF iron deficiency, giving IV iron with ferric carboxymaltose every 6 months. If patients were still iron deficient, and it similar to the earlier trials, it was technically a neutral trial, but had a higher bar just based on discussions with the FDA for this one. But in summary, what we found was a numerical reduction actually in mortality, heart failure hospitalizations as well, but a more modest benefit around 6-minute walk distance. So we can get into more of the nuance, but importantly, as we pool all of the data together, it does look like there's a clinically relevant reduction in heart failure hospitalizations as well. So that's led many of the clinical community and scientific statements now to not only know that IV iron is safe and improves function and feel endpoints, but it does appear to have benefits around reduction in heart failure hospitalization. Phew, that was a lot. Hopefully that is helpful to summarize a lot of trials, but I'm looking forward to some of your reflections on this and certainly getting back to our case as well.
That was really great and a good summary of, all that we've known about IV iron and heart failure thus far. So it sounds like going back to our case that Miss Ritten with her persistent symptoms could benefit from IV iron supplementation to improve her quality of life and even reduce her chance for rehospitalization. But the data isn't as clear on if it will reduce her risk of mortality. So at that time, she was treated in the hospital with IV ferric carboxymaltose and was eventually discharged home. When Miss Ritten came for our follow-up appointment, she had definitely noted improvement in her symptoms from NYSA class 3 to NYSA class 2 and questioned whether she should continue this treatment in the outpatient setting. So with all of the data that we've summarized so far today, what would you say are the most important things to think about for the clinician managing these heart failure patients in the outpatient setting?
Yeah, really a nice case that I think brings us all together. So in the hospital with heart failure, iron deficiency, received IV iron. And now you're seeing her in follow-up. Symptoms have improved. She's on otherwise good GDMT. Then you say, well, when do we need to think about rechecking her iron stores? And there's still evolving data in this space, but in HeartFit, we did it at a 6-month interval. And if patients were still iron deficient, we gave more iron. So typically what I'll do is whether in the in-hospital setting or out of hospital, we'll repeat those labs at 6 months, see if they need more IV iron, make sure we're doing this on a good background therapy of their other GDMT as well. I might underscore some other kind of key pearls. There were some concerns recently. Is there any interaction with SGLT2 inhibitors? We know that SGLT2 inhibitors improve clinical outcomes in heart failure across the EF spectrum, but there was a concern given some of the changes on hemoglobin. Everything we've seen thus far suggests that really the treatment benefits of IV iron are consistent regardless of SGLT2 inhibitors. But stay tuned because I know there has been some conversation in the space around that. And we are hopeful for additional trials that help better tease out the optimal definition of iron deficiency. I alluded to this a little bit earlier as well. And some of the data from HeartFib that have been recently presented at meetings, as well as from Ironman, suggests that it really is probably that TSAT less than 20% group that have the largest clinical outcome benefit. So stay tuned. Hopefully, we'll get more data in that space. But as of right now, we're really still looking at all of those iron indices and really using IV iron to improve quality of life, functional status, and potentially even heart failure hospitalization endpoints.
So, do you foresee any role for IV iron supplementation in patients with HFpEF? And is there any ongoing research in this space?
Yeah, this is a really exciting space, certainly with the evolution in HFpEF pharmacotherapies, now with SGLT2, thinking about GLP-1s. Interestingly, a trial was just presented at the Heart Failure Association in Lisbon just this past May, a small study, FAIR HFpEF. It was initially designed to be larger, but for a number of challenging reasons, it was just around 40 patients and did show with IV ferric carboxymaltose some potential benefits around functional status as well. So underpowered, but was technically a positive trial. So we'll hopefully see more data in that space. And then I'd be remiss if I didn't also highlight the ongoing FAIR-HF2 trial, a HFrEF study that's actually testing a little bit of a different hypothesis. The earlier studies looked at giving repletion or getting iron stores back in this range. And this trial is actually looking at more of a supplementation. So as long as ferritin levels are less than 800, it's actually giving additional iron at follow up. So I think that'll be a key study that should report out in the next year or so as well. So still important trials ongoing in this space to help better clarify how we can help our patients with heart failure really across the EF spectrum.
Yeah, sounds like a lot of great data to look forward to. Now, we've covered a lot of ground in terms of iron deficiency in heart failure, who to test, how to test, when to treat, how to treat, appropriate follow up. Rob, what are some key takeaways we should walk away with to hopefully help improve the lives and outcomes in patients with heart failure?
Yeah, thanks, Ahmed. So my top pearls would be again that when you see heart failure, think about iron deficiency. Don't wait for anemia. Remembering that definition, ferritin less than 100 or 100 to 300, with a TSAT less than 20. Some evolving data, maybe we can focus on just the TSAT, but we still need to prove that in randomized trials. And really, that oral iron is not going to be effective. We need to be giving IV iron, and that we have important data that this will help our patients feel and function better. And now, in the European guidelines, actually, a class 2 recommendation to reduce heart failure hospitalizations as well. So lots of different trials have reported out, and I think really an exciting time to think about the diagnosis and management of iron deficiency as a important comorbidity in heart failure.
That's really great, Dr. Mentz. We've covered a lot today. And so, just to close, I have to ask you what makes your heart flutter about iron deficiency and heart failure?
That's a great question. So for me, I think it's so exciting to help take care of patients and get them on their routine quad therapy, and you see this amazing benefits around clinical outcomes and LV remodeling. But the idea of the pill burden and what's really nice about diagnosing and treating iron deficiency is it's not another pill they have to take every day. It's pretty easy, whether in the hospital setting to give IV iron. There's a little more complexity in the out of hospital setting, but it's this nice concept of they can come in, get their iron infusion and hopefully feel and function and maybe have better outcomes as well. So I guess it would be the idea of it's another tool in our toolkit to really help our patients.
Dr. Mentz, thank you so much. And Shadley, it was so wonderful to get to record with you. It's always a blast. Dr. Mentz, we really appreciate your time and insights. You're a leader in this space. And so all of the cardio nerds, I'm sure, are grateful to hear. Thank you all for joining us. And we hope that you guys have a lot of great insights about iron and heart failure going out of this podcast.